Guardians of Caribbean Health, the vital role of family physicians. Across the sun-kissed islands of the Caribbean, family physicians stand as pillars of their communities. They are the trusted caregivers who know their patients by name, their histories, and their families. These dedicated professionals provide comprehensive medical care throughout their patients' lives. From the bustling streets to the tranquil shores of the Caribbean islands, family physicians are the first line of defense against illness. They treat a wide range of conditions, from common colds to chronic diseases. They are also instrumental in preventative care, promoting healthy lifestyles and early detection of potential problems. The importance of family physicians extends beyond their clinical skills. They are deeply embedded in their communities, understanding the unique cultural and social factors that influence health outcomes. This intimate knowledge allows them to provide care that is both effective and culturally sensitive. In a region facing challenges such as limited healthcare resources and rising rates of chronic diseases, the role of the family physician is more crucial than ever. Their dedication, compassion, and expertise are essential for building a healthier future for the Caribbean. A legacy of care, the Caribbean College of Family Physicians. For over 2 decades, the Caribbean College of Family Physicians, or CCFP, has been a driving force in advancing family medicine across the region. Established in 1987, CCFP is dedicated to improving the health of Caribbean people by promoting and maintaining high standards in general practice. The organization achieves this through education, advocacy, and fostering a strong network of family physicians. At the heart of CCFP's mission lies a commitment to people-centered, continuous care. This approach recognizes that healthcare extends beyond simply treating illness. It's about understanding the individual needs of each patient and providing holistic care throughout their lives. CCFP provides its members with valuable resources, including continuing medical education, professional development opportunities, and access to the latest research in family medicine. These resources equip physicians with the knowledge and skills they need to provide the highest quality care to their patients. Through its unwavering commitment to excellence in family medicine, CCFP plays a vital role in shaping a healthier future for the Caribbean. Its work empowers physicians to be effective leaders and advocates for the well-being of their communities. Global Impact, Regional Action, CCFP's partnership with WONCA. The Caribbean College of Family Physicians recognizes the importance of collaboration in addressing global health challenges. CCFP is a proud member of the World Organization of Family Doctors, or WONCA, a federation of 131 member organizations representing over 500,000 family doctors worldwide. This partnership with WONCA provides CCFP members with access to a global network of family medicine professionals, fostering the exchange of knowledge, best practices, and innovative healthcare solutions. It also allows CCFP to contribute to the development of international standards for family medicine education and practice. CCFP's commitment to regional action is evident in its active involvement in shaping health policy in the Caribbean. The organization has been instrumental in key health policy meetings, including the Nassau Declaration on Health and the Port of Spain Declaration. These declarations address critical health issues facing the region, such as non-communicable diseases and the social determinants of health. By actively engaging in regional and global health policy discussions, CCFP ensures that the voice of Caribbean family physicians is heard and that the unique healthcare needs of the region are considered. If you are a family physician committed to improving the health of the Caribbean people, we encourage you to join the Caribbean College of Family Physicians. CCFP membership offers numerous benefits, including continuing medical education, professional development opportunities to enhance your leadership skills, advocate for your patients, and contribute to the development of healthcare policies. Research and publications. Global connections. Join the Caribbean College of Family Physicians today, whether by direct membership, by chapter membership, and be part of a movement that is shaping a healthier future for the Caribbean. Together we can make a difference. Become a member and make a difference.
Good evening, everyone. to our distinguished colleagues, honored faculty, members of the International Society of Nephrology North America and the Caribbean Regional Board, partners and healthcare professionals joining us across Jamaica, the Caribbean region, and internationally. On behalf of the Caribbean College of Family Physicians, it gives me, Dr. Aldith Buckland, a Caribbean College of Family Physicians rep, great pleasure to warmly welcome you to this evening's academic session, the Nephrology Lecture Series, Diabetes and Chronic Kidney Disease. Let us begin with prayer. Almighty God, we thank you for bringing us together as healthcare professionals, united in service to humanity. Grant us wisdom as knowledge is shared this evening. May our learning translate into compassionate care, early prevention, and improved outcomes for the patients we serve. Bless our presenters, moderators, organizers, and participants. Guide our minds, strengthen our purpose, and remind us always that behind every diagnosis is a human life entrusted to our care. May compassion guide our science and excellence guide our practice. Amen. Again, greetings from the Caribbean College of Family Physicians. The Caribbean College of Family Physicians remains deeply committed to strengthening primary care, family medicine education, and interdisciplinary collaboration throughout the Caribbean. Diabetes and chronic kidney disease represent two of the most significant health challenges affecting our region. Family physicians and primary care teams are often the first point of contact for patients at risk, making collaboration with nephrology specialists essential in preventing progression, reducing complications, and improving quality of life. Tonight's program reflects the college's ongoing mission to deliver high-quality, practical, continuing medical education that bridges primary care and specialty medicine. We have a collaboration with the International Society of Nephrology, North America and Caribbean Regional Board. And this collaboration is really very important. Healthcare challenges such as diabetic kidney disease demand coordinated regional responses. Through collaboration between family physicians, nephrologists, researchers, and healthcare leaders, we strengthen early detection and prevention strategies, knowledge exchange between primary and specialty care, regional research and capacity building, improved kidney health outcomes across Caribbean populations. The Caribbean College of Family Physicians values this collaboration immensely, and we look forward to continued joint initiatives that advance kidney health and patient care across our region. We have a very important person and other person in our midst. First of all, our moderator, Dr. Lorianne Fisher. It gives me great pleasure to introduce her to you. Dr. Fisher is a distinguished consultant nephrologist and intensivist based in Jamaica and serves at the University Hospital of the West Indies, Mona. She completed her MBBS with honors at the University of the West Indies, followed by advanced training in internal medicine and nephrology in the United States, including nephrology fellowship training at the internationally renowned Johns Hopkins Hospital, where she also completed critical care training. Dr. Fisher combines clinical excellence with academic leadership. She serves as a lecturer within the Epidemiology Research Unit at the Caribbean Institute for Health Research at the University of the West Indies and has contributed significantly to advancing kidney health knowledge within the Caribbean. Her clinical expertise spans chronic kidney disease and end-stage kidney disease, dialysis care and hypertension management, kidney complications associated with diabetes, lupus, and sickle cell disease. Her research interests focus on understanding kidney disease within the Caribbean populations including the epidemiology of chronic kidney disease, sickle cell nephropathy, lupus nephritis, and acute kidney injury related to systemic lupus diseases and systemic diseases. Importantly, Dr. Fisher currently serves as chair of the North America and the Caribbean Regional Board of the International Society of Nephrology from 2025 to 2027 term, where she continues to champion regional collaboration, kidney disease prevention, and professional education initiatives. Beyond academia and clinical leadership, she is also well known for her public outreach efforts, educating communities on kidney health awareness and prevention. We are therefore honored to have such an accomplished clinician, researcher, educator, and regional leader guiding tonight's discussions. Dr. Fisher will now assume the role of moderator and will introduce our distinguished keynote presenter, Dr. Suman Behara. Dr. Fisher, the virtual floor is yours. Thank you.
Hi, thank you, everybody. And thank you very much to the CCFP for hosting and being such an integral part of this initiative. We started this initiative about 2 years ago, aiming to improve the knowledge and collaboration between nephrologists and primary care physicians on kidney health. We acknowledge that kidney health is oftentimes our patients are referred from the primary care physician, our point of entry, our patient's point of entry into care. And therefore, your role is extremely important in detecting and managing kidney patients living with kidney disease. And so I hope our efforts will only expand as we recognize the growing epidemic of kidney disease. And we present a very important topic, which is diabetes and chronic kidney disease. And I'm very honored to introduce a very excellent lecturer. I'm sure you'll have a wonderful time listening to her today. Her name is Dr. Suman Behara, and she's a dedicated Canadian nephrologist whose work spans clinical care, research, and global kidney health. She works at South Lake Health, a regional cancer and cardiac center, and holds a position as an adjunct assistant clinical professor at McMaster University, Faculty of Health Sciences. Dr. Behara contributes a lot to the International Society of Nephrology, North American Caribbean Board, where she supports a lot of our initiatives to enhance kidney care and capacity and education worldwide. Additionally, she serves as the ASN Kidney News editorial board, fostering scientific communication and leadership through the nephrology community. Her research expertise includes chronic kidney disease, rare kidney disorders, and onconephrology, with a growing focus on what is now, as our knowledge improves about kidney disease, the phenomena of cardiovascular kidney metabolic medicine. She's played a role in many educational facilities. So she's a key role in the development of the ISN, renin-angiotensin inhibitor, and SGLT2 clinical toolkits, collaborating internationally with nephrologists and cardiologists to promote evidence-based management of cardio-kidney complications. She also participated in the ISN-led International Expert Forum on CKM diseases in Amsterdam in 2025. And she's very committed to global kidney care, and education. She partners with many organizations in low and middle income countries and champions equity-focused kidney care initiatives in Canada. Her work exemplifies scientific excellence, interdisciplinary collaboration, and a passion for advancing kidney health across diverse healthcare systems. And without any further ado, I'd like to introduce Dr. Behara. She's going to present today on diabetes and chronic kidney disease. And thank you.
Thank you, Lori. Thank you, Dr. Fisher. I mean, that was way too generous of an introduction. Dr. Fisher is the one who does all the hard work. Without any further ado, I'm going to start sharing the screen, and hopefully I won't land into any technical difficulties. And Can we see the slide screen right now? And can anyone confirm that we're on the right screen?
Yeah, we are.
Yes, we are.
Okay.
We're good.
Well, actually, it doesn't look like it went full screen.
It's not full screen right now. Let me just go.
Perfect. And let's go back to slideshow.
While we're doing
Perfect.
this, some kind of housekeeping before we start. So we'll do the questions at the end. Usually we have a very nice extended Q&A at the end. So please put your questions in the Q&A section. And go ahead, Dr. Behara.
Okay, perfect. And okay, right now this is I think it's a full screen right now.
Yes, perfect. Thank you.
Perfect. Okay. So the presentation for today is part of a ISN lecture series, and we're going to concentrate on diabetes and chronic kidney disease, which is a very, very important diagnosis, and we need to know how to manage it. Of course, our general practitioners, family doctors, and internists are the front line, and the care starts over there. So this is pretty important topic. We're going to touch upon all the guidelines from KDIGO in association with the American Diabetes Association. Diabetes Canada had some 2025 guidelines updated, which is basically coming from the KDIGO guidelines, and of course ISN, the International Society of Nephrology. So our objectives for today, from this presentation, upon completion of this presentation, we're hoping to have a very clear understanding of what the definition of CKD is. And then we would go on to include and interpret what routine screening for CKD would look like, how to integrate that into our clinical practice, the role of urine albumin creatinine ratio and GFR. We're going to touch upon the pillars of care of the different medications and management, lifestyle, etc. And then all of this knowledge put together, we'll be able to integrate all of this into the latest, the KDIGO guidelines, ADA, Diabetes Canada, all of those guidelines into our clinical practice. So that's the hope. Okay. And when it comes to defining CKD or chronic kidney disease and diabetes, it's pretty simple. It's just two criterias, either, so you do either 1, 2, or both. One is albuminuria, more than equal to 3 milligram per millimole. And this is usually taken over a 3-month period. You see that there are 2 urine samples that are over that cutoff, and that would be one of the criterias. Second criteria is, of course, an eGFR of less than 60. Either one of those or both would be considered CKD. Diabetic nephropathy would be a combination of these two, or albuminuria by itself. So usually we're used to GFR being our go-to test, but albuminuria turns to be very important, and it's actually more important than the other one. The other one's important, but albuminuria is significant. Of course, there are certain things that we have to look for. There's some transient albuminuria, which we commonly see in our practice when a patient walks in with either, there's some physiologic cause, or there's recent major exercise, urinary tract infection, severe febrile illness, decompensated heart failure, menstruation, acutely severely elevated blood glucose or blood pressure, either of those. They can cause a transient albuminuria, so that's why we need to just recheck it, repeat the test, see if it's persistent even after these causes are not existent anymore. Now, we went into, I got some data for Jamaica specifically, and there was International Diabetes Federation has Jamaica is one of their partner countries, and what was seen as diabetes in Jamaica in 2024, it's about 2 million. So there are about 2 million adult population in Jamaica, out of which 12.5% prevalence was seen of diabetes, which is roughly around 236,000 people with diabetes. North America, Caribbean region in general consists of about 10% of the population that has diabetes in the entire world. So it's pretty significant. And 33% of those with diabetes will eventually they'll lead to kidney failure with or without requiring dialysis. And a lot of the population that has kidney disease in diabetes are going to experience some sort of heart disease with an increased risk for cardiovascular deaths. So why is it so important? As we just discussed, we're facing an epidemic of diabetes and hypertension put together, especially these are the leading causes of CKD in Jamaica, all over the world as well, and a major driver of mortality and morbidity. General practitioners and internists are, of course, the first point of contact. Yes, so that provides us with the greatest opportunity to intervene early on in the disease and prevent severe end-stage kidney disease. Early action saves lives, prevents progression, and our aim is to equip all of you with the latest evidence-based strategies from KDIGO and ISN to effectively screen, manage, and slow down the progression of CKD in all of your diabetic patients. So CKD is pretty common in type 2 diabetes, as we just discussed, and most of them have early stage disease, so great opportunity to intervene. 1 in 2 adults have type 2 diabetes, and 1 in 2 adults with type 2 diabetes have CKD. So that's about 54% of patients will have stage 1 or 2 diabetes with a GFR that's below what's the normal or the norm. And as the CKD progresses, the patient's prognosis declines. This is just a heat map that most of you are familiar with. Usually I see this in a lot of our general practitioner and family medicine, family doctors' offices. It's right there on the wall, which is great because it's so prevalent to see these. We will just go through very roughly what this is all about. The the x-axis has albuminuria, which is A1, 2, and 3. And here's this corresponding albuminuria measures in mg per millimole. Then we have GFR on the y-axis. And then right here, the green ones are usually low risk. Yellow is moderate risk. Orange is high risk, which is these two right here in A3, G1, and 2, and these two right here, which is GFR grade 3, CKD 3, however, might have albuminuria A2 or A1 or A2. You don't need to memorize this at all because this is usually something that you can put on your wall. And very high risk are the reds and this coral color right here. The later the stage, more irreversible their CKD, hence early intervention is crucial. So if we are able to intervene when this is still green, yellow, or slightly orange, we can still, put a halt to the progression of the disease. Now, the presence of kidney disease predicts cardiovascular disease and mortality. As we discussed earlier, cardiovascular disease is the major cause of mortality in patients who have a kidney disease. And especially if you pair it with diabetes, then that just increases several folds. So things that we're looking for: increased albuminuria, more than 3 milligram per millimole, and that increases the risk of coronary heart disease by about 1.5 times. And if the GFR is below 60, that increases the risk again for cardiovascular mortality and heart failure by 3 times. So what are we doing? We're going to include these two tests, the urine ACR, which is the albumin creatinine ratio, and GFR testing for our patients with type 2 diabetes in our clinical practice as a general rule of thumb. So screening for kidney disease in individuals with diabetes, what do? We screen them annually. And so people who have diabetes and there's no history of kidney disease, you still screen them annually. You'll be surprised how many times you'd find people who weren't in the criteria 1 year ago, and then they finally have started showing some signs, and that's when we can intervene. For type 1 diabetes, things are a little bit different, where since they're at a younger age, you start their screening 5 years after the onset of their disease. If it's really early on in a child, you usually start in puberty or after puberty, and then you do it yearly. We might need to do it more frequently, depending on how fast the progression is. And for people with type 2 diabetes, of course, you start at diagnosis and annually thereafter. The screen with random urine ACR and creatinine, and then there's something called KFRE. And we'll talk about KFRE, and it's a risk calculator, and we'll talk about that in the next slide. So if the urine ACR is positive but less than 30 milligram per millimole, so it's between 3 and 30, then we repeat it again within a 3-month period. If we see 2 of them, that means there is, the risk is pretty high. And if it's more than 30, then it's definitely a diagnosis of diabetic nephropathy. Again, CKD, GFR less than 60, and urine ACR more than 3. Diabetic nephropathy is more than 3 with less than 60 and more than 30. Sorry, that should be more than 30 definitely, and more than 3 on 2 repeat occasions within a 3-month period. So albuminuria, again, I cannot stress on this enough. It's a very, very important predictor of cardiovascular disease and mortality in type 2 diabetes. So if you actually look at it, most people would talk about serum cholesterol and discuss that with their patients. They'll talk about blood pressure. They'll discuss that with their patient, and smoking as well. All of these are discussed. And then when it's microalbuminuria, it's usually for the most part, taken quite lightly. If it's in the range of a single digit. So if it's more than 3, it still significantly does increase the risk of cardiovascular mortality, so it should be taken into consideration. Okay, so we already discussed that. So let's talk about this. So let's say we have a patient, Miss ABC. She has a GFR of 83, which is normal or, within an acceptable range, has a urine ACR of 16 milligram per millimole. So what is their risk of CKD progression? We're going to discuss this. I'm not expecting an answer right now. Let's just think about it. There you go. So we touched upon this heat map earlier. So 83 with a GFR 83, she's got this mildly decreased grade 2 CKD, which if she did not have any urine ACR that was significant, it would be a green zone, would be a low risk. However, she has, I believe I said 16. Yes, she has a 16 milligram per millimole urine ACR, which puts her into this zone right here. That's a moderately increased risk. And even here, there's a chance to intervene and slow down her progression of the kidney disease. All right, we talked about KFRE earlier. That's a kidney failure risk equation. What that means is that it's usually people who have diabetes, even if they don't have diabetes, but mostly it's seen in people with diabetes. They have stages, CKD stage 3 to 5. And this is a risk calculator for how fast they're going to progress to an end-stage kidney disease over a 5-year period. I know in Canada, this is one of the criterias for referring a patient to a nephrologist, or more so MCKC, which is a multidisciplinary care kidney care clinic. So what happens if a KFRE score is more than equal to 5%? That means they have a high risk of progressing in the next 5 years to end-stage kidney disease requiring, renal replacement therapy, be it dialysis or transplant, or just they're going to progress to stage 5 CKD. What this calculator, it's an online calculator. There's a QR code right here that you could take a picture and see what it is, or you could just click on this link as well and it would take you there. It takes into consideration the age, gender, GFR, and urine ACR. In North American calculators, there is one of the slots that says whether the patient is of North American origin or not, which I find is a very iffy question, so we're not going to touch upon that. But that would give you the grade of progression. It tells you two numbers. One is a 2-year progression, one is a 5-year progression, but it's very helpful in knowing, even for yourself, how you should be counseling this patient. So in this lecture, I got a lot of data from KDIGO, and of course, I also went into the consensus report from 2022. And the executive summary as well. I believe the consensus report was in 2020. It was released in 2024, but it takes into consideration the KDIGO guidelines 2022 for diabetes. So if you look at this on your right, this is for management of diabetic kidney disease. This is the pyramid that you can see on the KDIGO website. It is pretty simple, but I just oversimplified it here just for ease of our eyes. At the end of the day, we're not all very, not everyone's fortunate enough to have a very high attention span. So we'll go with more colorful, less words. And if you look at this pyramid right here, at the bottom, the management of diabetic kidney disease, as you can see, it includes not just medications. There's lifestyle modifications that need to be done. Then there are certain blood pressure controls and other cholesterol levels that we should be aware of. So if you look at the bottom of it, every single patient needs this and meets this criteria for the blue, which is in their food, it doesn't have to be plant-based, it's more plant-dominant. So they could still have their, eggs and lean meat for protein, but it should be plant-dominant. So there should be a good source of vegetables and fruits in their diet. Exercise, getting up, being active, cannot stress upon that enough. I'm pretty sure you guys stress upon that enough with your patients as well. Smoking cessation definitely, decreases the cardiovascular risk as well. Weight management is key in diabetes management. Next, we move up the pyramid. We go to this magenta area right here, and that talks about your BP targets to be less than 130/80 for people with diabetes. LDL cholesterol, it says less than 2. We are a little bit more lenient with our patients. We give them a cutoff of less than 3. So it usually really just depends on what the lab values are, but I think mostly less than 3 is decent for LDL, and HbA1c levels of less than 7 for diabetics. If they're especially under the age of 75, above the age of 75, you could be a little more lenient with them. But by little more lenient, I just mean 0.5. And then the next step would be RAS blockade, renin-angiotensin-aldosterone system blockade, which is crucial. That's the step 1 that should be done in almost all patients if they're hypertensive with diabetes. If they have proteinuric disease with diabetes, then that's crucial. And then the next step up is the other treatments like SGLT2 inhibitors that brings in empagliflozin, dapagliflozin, and canagliflozin. Then we have the non-steroidal MRAs. It's very important to realize this is not the steroidal MRAs. Steroidal MRAs would be the spironolactone, but we're talking about finerenone mostly with the non-steroidal mineralocorticoid antagonist. And then the fourth pillar of diabetic kidney disease is GLP-1 receptor agonist, which is the semaglutide, liraglutide. Those ones, semaglutide is more common now, and adding that would add more kidney and heart protection. This is again coming from the Diabetes Canada 2025 guideline, but it's basically what has been discussed in KDIGO guidelines as well, that there is very, very strong evidence, which is grade A, level 1A evidence for including RAS blockade, SGLT2 inhibitor, GLP-1 receptor agonist, and non-steroidal MRAs, these to be part of diabetes management when it comes to diabetic kidney disease. Now I think most of us are more acquainted with using RAS blockade as step one. So we're just going to move on to SGLT2 inhibitors. I will come back to RAS blockade, etc. Later on in the slides when we talk about certain toolkits that ISN has for all of you to use. They're very exciting and they're very useful, so we'll touch upon that later. And then when we talk about SGLT2 inhibitors, usually they have excellent cardiovascular and kidney benefits. They reduce mortality and morbidity for patients. Actually, it's even with or without diabetes, but we're talking about diabetes right now, so we'll talk about diabetes. So in patients, you see significant decrease in the risk of kidney disease progression, acute kidney injury, and cardiovascular death or hospitalization from heart failure. And when it comes to metabolic benefits, this is something that is more visible to the patient. They can see that their HbA1c numbers are coming down. Their body weight actually does come down as well because they're literally peeing out sugar. And then their systolic blood pressures also have a slight improvement as well. Okay, and there's an important risk factor that almost everyone talks about because most patients now go to ChatGPT before they come to us. And they'll ask about, oh, I don't want to start this because, there's Fournier's gangrene. As a first-year med student, I didn't even know how to pronounce Fournier's gangrene, but these people are great. They know how to say all of these things. So they'll come back to you and say that, oh, I don't want that. I don't want amputations because, and it causes a lot of UTIs. So usually the benefits outweigh the risks, and that is why the physician is recommending it to them, is what we usually tell them. And the risk of Fournier's gangrene is, I believe, is about 1% or less than, it's less than 1%. And most of them are women, so they don't have to worry about it. But euglycemic ketoacidosis is one of the risk factors that's there. So if somebody has a history of euvolemic diabetic ketoacidosis or just diabetic ketoacidosis where they're more prone to it, that's where I would be more cautious about starting them on it, but otherwise it should be okay. And then when we talk about GLP-1 receptor agonists, these are mostly, again, semaglutide, liraglutide. Most common ones that we recently had a lot of buzz about was Ozempic or Wegovy for weight loss, but then Ozempic was the trade name. That FLOW study was actually stopped early on before even their end date because they had such good cardiovascular and kidney benefits. The primary outcome was we saw a 24% reduction, risk reduction for major kidney disease events, and a composite of onset of kidney failure also got reduced significantly. The cardiovascular death also significantly was reduced, almost about 30%. Then there was secondary outcomes which were major cardiovascular events. The first event, the rate decreased for that. The rate of death from any cause decreased as well. And the GFR was preserved more so annually when they got their checks. So it did have significant benefits. Finerenone, when we talk about finerenone, it's usually the non-steroidal mineralocorticoid receptor antagonist, and which is, we call it spironolactone's brother, but or sister, but this is non-steroidal, that is steroidal. So that has more of the side effect profile than finerenone. Finerenone is a little bit more tolerable than that. But in heart failure patients, however, it's different. Spironolactone is preferred till date. There are new studies coming out where finerenone is being suggested. But when it comes to diabetic kidney disease, that's when finerenone has increased efficacy as a non-steroidal MRA. There are a few trials that were done. There was Fidelio, DKD, Figaro, DKD. They all kind of had the same thing where they had reduction in cardiovascular morbidity and mortality risk. And there was a decrease in hospitalization from heart failure as well, close to about 20%. Which is significant. And when it came to kidney disease, there was a decrease of 23% in the risk of CKD progression and a 20% reduced risk of advancing to end-stage kidney disease. 32% actually had a urine ACR decrease as well, which is quite significant. They were well tolerated. There is a risk of hyperkalemia that is seen. So we're just going to touch upon that in one of the later slides as well, because that's a clinical thing that you will experience in your practice as well. So the modern therapies that were added on after the RAS blockade and SGLT2 inhibitor, all the SGLT2 inhibitor widely got introduced in 2020-ish, but now that's ancient compared to what is coming on new, which is finerenone and GLP-1 receptor agonist. So the KDIGO recommendations is use of glycemic control in patients who do not achieve their targets with SGLT2 inhibitors and metformin, or they just cannot use them because they have a contraindication to using them, like lactic acidosis or euglycemic diabetic ketoacidosis, or they had recurrent severe UTIs with SGLT2 use, which is also seen, especially in women. A lot of times it is combated by increasing their fluid intake, but it's seen. So that's one thing. Again, finerenone or NSMRAs or non-steroidal MRAs. It's considered in patients with type 2 diabetes and CKD who have persistent albuminuria. Despite being on ACEs and ARBs, ACEs or ARBs, you never give them together. ACE or an ARB should not be given together. It was given together in the earlier practice, but not anymore. So these two, these four are the pillars of diabetic kidney disease. When people say GDMT, they usually talk about cardiovascular health, but why not talk about GDMT or guidelines based medical treatment? Why don't we talk about it for kidney disease? When it comes to diabetic kidney disease, we actually have earlier, maybe 10 years ago, we weren't as well equipped, but now we have RAS blockade as our first pillar, SGLT2 inhibitors as the second pillar. Then if you need more help, either non-steroidal MRAs can be added, and then GLP-1 agonist can be added. After the RAS blockade, the other ones, the sequence does not really matter as much anymore. Earlier, they were started in a sequence, but now sometimes you do weigh out that if somebody is diabetic but also has hypertension, then we're good with giving them RAS blockade and then adding on the SGLT2 inhibitor. Let's say somebody is always hypotensive and they're not tolerating the RAS blockade. At least now we can give them the SGLT2 inhibitor. When we talk about non-steroidal MRAs, they're not a very strong antihypertensive, so they do have some benefit in people who have softer blood pressure readings. Now this is just what we talked about, how if we see, adding earlier the conventional therapy, which is this maroon line right here, was usually just adding the RAS blockade and having diabetes management. But now with the combination therapy of SGLT2 inhibitor, GLP-1 receptor agonist, non-steroidal MRAs, we see this is the result with the combination therapy, where people have a better mortality, morbidity benefit. This is the kidney event-free survival right here, and this graph right here talks about the heart failure-free survival, which is also improved with the combination therapy. Okay. This again talks about that, but it's a little bit more graphical interpretation of it. So the effect of early intervention, if you look at this, the trajectory of CKD, this is normal aging, the green line over, or the teal line over here. If there is no intervention, then there's a drastic decline in health and kidney failure much earlier in life. If there's a late intervention, maybe you're intervening right here, there's some improvement and you're delaying the progression of kidney disease by a little bit, but not as much. But if you look at the early intervention and you're intervening early on in the disease, then the life expectancy, mortality, morbidity benefits are much more. Okay. This one just talks about how to titrate doses. It does not really have to follow this timeline, but this is just for a graphical idea of what we're trying to do and what we're trying to achieve. So usually there's a traditional approach where you do it much slower over a course of a year and a half. You're introducing one medication after the other. Then there's an accelerated one where within a year or 10 months, you start one, 3 months later you add on the other one, 3 months later you add on the third one. So you're doing a much accelerated approach to that. And then the rapid sequence is something that is there, but then most family doctors in our communities are not very comfortable with this. So I'm not really going to advocate for that. It takes a little bit of getting used to. So right now, I would say first maybe doing it over a year or a year and a half, and then slowly trying to see if that somebody's a little bit younger is able to tolerate better, then maybe an accelerated or rapid approach can be applied. But things that you should always be aware of is their potassiums. Both ACE and ARB and non-steroidal MRAs have the propensity of increasing potassium levels or giving you hyperkalemia. SGLT2 inhibitors, not really. They actually surprisingly have a little bit of a potassium decreasing effect. So you could add it for that reason. And then hypovolemia is very important. It just says SGLT2 inhibitors here, but hypovolemia, it causes hypovolemia because of the diuretic effect, but I think when there's hypovolemia, you have to be careful in all three classes, RAS blockade, SGLT2 inhibitor, and non-steroidal. You should always warn them that, hey, if your blood pressure is lower than 100 systolic, or if you're dehydrated, you're having diarrhea, vomiting, any of those, please stop these medications for that many days and then resume once you're feeling better. Same goes with metformin as well. There you go. Now, when to refer to the nephrologist. There are clear KDIGO guidelines and referral criteria. It says if there's advanced CKD where the GFR is less than 30, that's an immediate referral to the nephrologist. Then there's a rapidly declining eGFR where the trajectory is just not going. Normal eGFR decline would be about 1 ml per minute per year. If it's more than that, then that would be warranting a nephrology consult. If there's persistent, significant albuminuria, then definitely that's a cause for concern. And uncontrolled hypertension, despite having 3 or more medications on board, is a definite nephrology consult. Persistent electrolyte abnormalities, don't give it a second thought. Lori is not gonna thank me for this most likely, but then yeah, those are some of the causes. And then, of course, if you're suspecting that this is not diabetic kidney disease, most family doctors are more than comfortable treating them. But if it's something that you've seen that this does not fit the criteria, then definitely refer them to the nephrology so they can have a clear, complete, thorough workup for the other causes. Now, I was talking about the toolkits. So these are some of the toolkits that ISN has made, and it's there for use by everybody, mostly by family doctors, GPs, internists, also for nephrology and cardiology, cardiologists as well. But it's very important for our first line of physicians. So there's some common things, like if you look at this side right here, there are lots of toolkits that are available. I do have links to them in another slide, so I can share that. I'll share that later as well. So if you look at it over here, there's some that says, if you're, this is one of the roadmaps or the nuts and bolts of, what is an indication to start a RAS blockade, what is, early monitoring, what to look for in the long term, things like that. And then the potential issues that come up, like hyperkalemia, metabolic acidosis, acute decline in their kidney function. When is it a cause for concern? Those things all can be found right here. If you go to this link right here, it says RAS inhibitor optimization toolkit. Then you can see all of these links and drop down menus right here. The one that I showed you is the overview, this one, overview nuts and bolts. Then you have another one that says addressing challenges. This is when you have hyperkalemia, what to do, when to intervene. That would be right here. Then you could click on this one. This talks about other things like, there's a change in kidney function where there's a drop in GFR significant. What do you do when it's concerned? When you should stop it, when you should half the dose. This is what it talks about. And then they're addressing other things like, dietary approaches to hyperkalemia and things like that. This again is one of the things with the toolkits for SGLT2 inhibitor. This just talks about, when and how to use it, the indications, and this is basically the nuts and bolts of SGLT2 inhibitor, high-risk patients, long-term management. So you don't have to grasp all of what we're talking about today. You could just go on the ISN website and go to the toolkits and avail all of these practice points and everything. It's there. There's sick day medications, when you should stop it, what drugs interact, mostly if there's a lithium on board, digoxin, then these are things that you should just be careful and warn the patient about. Just do a regular blood work as well if you need to start them on a SGLT2 inhibitor. Then these are the ones that talks about the necrotizing fasciitis, Fournier's gangrene, some of the side effects. Genital infections and hypovolemia are quite common, but then the other ones that you see in green right here they're not as common. Then this is a unique thing that actually I worked on along with one of our cardiology colleagues. It's called the SGLT2 inhibitor cold map. We all saw the heat map and we're quite used to a heat map and seeing that heat map there and when to, when is it a concern. But then SGLT2 inhibitor, we devised a cold map. What that does is that all of this, so GFR of 20, up until a GFR of 20, it is okay to initiate an SGLT2 inhibitor. And those are as per KDIGO guidelines. You could just start them until a patient is at about 20 GFR. And this blue zone, solid blue zone right here actually talks about, shows a cardiovascular and kidney risk reduction. And then this dotted these two right here, these dotted ones, they only show a risk reduction when it comes to heart failure. So it could be heart failure with reduced ejection fraction, moderately reduced ejection fraction, or preserved ejection fraction. But that is when, if the patient has heart failure, then they can be started early on. But otherwise, you're looking for either a higher grade albuminuria, or you're looking for grade 3 CKD and above to start the patient on SGLT2 inhibitor. These are actually also a part of the toolkit for SGLT2, where these are certain patient guidelines where if the patient has certain questions, these can be provided to the patient. So it talks about where and why, why the patient is being given SGLT2 inhibitor, what are the benefits, things like that. So this is really good for the patient. It's a patient information sheet. This is also a patient information sheet for potential side effects. However, I find that this is very helpful for our GPs as well, when it talks about what are the potential side effects and what steps can be taken urgently and what you can advise your patient. So this talks about that. Mostly talks about, keeping your hydration well would be one of the major points that you're hitting, and not to take the medication if there's a UTI or there's very low blood pressures. Now, when it comes to non-steroidal MRAs, then there is the finerenone that we talked about. There are two sections. If you go on the website of the toolkits, there are two sections. There's a top portion that talks about steroidal mineralocorticoid use, which is in heart failure patients. And the bottom is this toolkit right here. And this talks about when not to start it. Usually, I would say if the GFR is less than 25, then steer clear of it. Do not prescribe it. And otherwise, it's okay to be prescribed to the patient. Now, things that you should be checking for when starting a non-steroidal MRA or finerenone is, of course, you're looking at the GFR and the albuminuria, but then you have to be careful about the patient's potassium. It is a mineralocorticoid receptor antagonist, which does increase the potassium, although less so than spironolactone, but it does increase it. And when it is more than 5.5, that's when you hold the finerenone, you don't give it to them anymore. You recheck the potassium, and then you kind of might think about restarting it if it's less than 5. If it's more than 6, definitely direct them to the hospital, give them, potassium binding resin or something to get the potassium out of their body. Advise them for a low potassium diet as well to stick to it. But then there are certain gray zones. It's like if it's less than 4.8, it's okay to carry on and initiate the medication. If it's between 4.9 and 5.5, then you are cautious. Your Kerendia has, or finerenone has 2 doses, 10 or 20. You can ask them to start with a 10, although 20 is the suggested dose. I don't think a lot of my patients are more frail and they don't tolerate 20. So I start them on 5 and give them 10, but usually they recommend 10 or 20. And also doing blood work. It does say every 4 months. Some of our patients are a little bit more antsy about letting go for such a long time, so maybe they can have a more frequent blood work. That all depends on the individual being treated. GLP-1 agonist and statins, those are again things that are recommended, highly recommended. GLP-1 receptor agonist has a class 1B recommendation, which is quite strong by KDIGO, to be started in type 2 diabetes with CKD. And then you have the statins, which is anybody who's diabetic, usually above the age of 50 needs to be on a statin. But even if they're between the age of 18 and 49, and they have CKD, but they're not treated with dialysis or transplant, it's suggested that they are started on it. There's stronger evidence for people over the age of 50, but definitely if even younger, it decreases the stroke risk and cardiovascular risk, like MIs. This again is a picture of the toolkits. There is Cardio Kidney Metabolic Initiative, which is a new initiative by ISN. It has a very neat, if you go on that website, it has a very neat, I want to say a scale where you could draw down, there's a cursor, you can draw it down to where the person's GFR is, and it would show you what their risk is like, how they would improve, and it's very neat. So I would definitely suggest to go on these websites. It's basically the isn.org initiative/toolkits, and then you can find the optimization of RAS blockade, SGLT2 inhibitor. The one for MRA is actually hidden under the optimization of RAS blockade one. And well, the take-home messages is you are the key to saving kidneys because you are the first line. Patients are seeing you first. Screening is mandatory. Like, I cannot stress on it enough. It's so important. Both GFR and urine ACR, super important. Management-wise, you adopt a comprehensive approach. What you focus on is the glycemic control, also their blood pressure, and then stage by stage you start the kidney protective medications, because now there are so many that we can actually decrease and delay the progression of kidney disease. They don't really have to go on to dialysis. So all of that is great news for nephrologists and also for the patient, also for their treating physicians, family doctors, everybody. And then make SGLT2 inhibitors a cornerstone as well. RAS blockade has now become one of the cornerstones. Now SGLT2 inhibitors should also be sort of integrated in there as well. It does decrease fibrosis, which decreases inflammation as well in the body, decreases cardiovascular and kidney risk for progression or mortality, morbidity in a 10-year span. Definitely use the ISN KDIGO toolkits. And yeah, so those are it. This is how to screen, who to screen. So who and when to screen is type 2 diabetes, yearly starting at diagnosis. How to screen, two things: urine ACR, eGFR. And what do you do with a positive result? You repeat it, you confirm the diagnosis, and then you initiate evidence-based treatment like we talked about in that pyramid, and the 4 pillars of diabetic kidney disease. And we all know now what defines CKD. I think I stressed upon it so many times that you probably want me to be quiet now about all CKD related things, and you're all experts. Well, I think that is all. And
Thank you, Dr. Behara, for such an excellent presentation. It's very useful in that it's very practical, because especially now that we're getting more of these medications available to us, the importance, even more so, is identifying these patients early. And I think you stressed that very much in the in your presentation. So thank you very much. I'm gonna go to the questions in the chat, and which were a lot. So I'm gonna start with one. The one that I answered actually, and I'm gonna, because I think it's a very good question. It's on somebody from Mexico. He said that albuminuria, upper limits like 300 milligrams per gram. And I noticed that, like, we have difference in units, right? So I know in Jamaica, we tend to use the milligram per gram, right? And in Canada and in the UK and some Caribbean countries too, they use milligrams per micromole, right?
Yeah.
And those are different units. So no albuminuria in the milligram per gram, it would be less than 30, right?
Yeah.
That's A1. A2 would be between 30 and 299, and greater than 300 is A3 or the severe. And then Dr. Behara had also said, like for those labs that use milligrams per micromole. So be cautious. Remember just to always look at the units that they're using because it's a different cutoff point for units. So his question was really good, which is, the albuminuria upper limit, like severe albuminuria, is a strong predictor for coronary artery disease. Could you explain why?
Actually, there was a very good slide that I had that I took out because of time constraints. There was a very good picture of a bullet train approaching the end of a cliff. And after the cliff, there's also a fall, but very morbid. But the rate at which the bullet train is progressing, if you look at a GFR, if there's a GFR decline that's slowly happening, then the bullet train is slowly approaching towards that cliff. But as soon as the urine ACR comes in, the bullet train is just exponentially speeding up and going to fall off the cliff right away. I think there's a lot to do with the filtration mechanism itself and like physiologically that's being broken because of all the high glycemic index and then the blood glucose level being too high, the renal clearance of sugar. There's more sugar, more damage, like mechanical damage to the kidneys filtration system. Now, if there are big holes, if you imagine there are big holes in the kidneys filtration system, it's very difficult now to fix the holes again. So it's a stronger predictor of how fast, and that causes more inflammation. And those I think would be more of the reason why it's progressing so fast towards it.
Right. And I think that's right. That's why we kind of want to stress the importance of testing for this, right? Because oftentimes as nephrologists, we see that when the GFR is low, but and oftentimes we do this when we're in practice, we check a renal panel or, a kidney function test, but we forget to test the urine, and the urine is actually really important because albuminuria itself is like a marker of endothelial dysfunction, Dr. Behara said, it's a mark of endothelial dysfunction, and that endothelial dysfunction is not only happening in the kidney, it's also happening throughout the blood vessels, right? So albuminuria by itself increases the risk of all-cause mortality, cardiovascular mortality, progression to kidney failure, and even acute kidney injury. All right. So it's a measure of endothelial dysfunction and therefore a higher risk of kind of accelerated atherosclerosis and generalized inflammation and therefore, cardiovascular death. So please, one thing we want to say, please check the urine. Please check the urine. It's creatinine and urine. Okay. So I'm clapping, but yes, please. All right. So that's one question. I hope we answered that question well for the audience member. One question, which is, how about the dietary management for diabetic nephropathy? And I think you did touch on that.
Yeah, so we asked them to be on a more of a plant dominant diet. I used to say plant based diet, and then I have steered clear of that word because plant-based means everybody says I'm not going to become a vegetarian overnight. But yeah, no, you don't have to become a vegetarian overnight. It just means you have to have a lot of fruits and vegetables in your diet. Also, based on your potassium, be wary of those high potassium rich food and avoid those. But then it's very important to know that people, when they come after reading something on Google, they come with lower stages of CKD, but they're not eating anything nutritious that has potassium, but the potassium has never been a problem. So I don't usually use that word potassium until and unless that patient is in a high grade CKD and has a potassium issue. I don't touch upon that word at all. Mostly I would talk about a plant dominant diet. Lots of like water-based vegetables are good. Diabetics have to be careful about their fruit consumption, juices especially. And otherwise, if you could tell them if you want to have a juice, just pick up the fruit instead. But also for fruits that the pure sugar. I mean, fruit sugar, but still it's sugar. That's going to give them a sugar spike. So those are the things that you have to be very careful about. Increasing fiber in their diet, definitely, and water intake. If they don't have any issues with cardiometabolic diseases or, increased swelling over their feet or anything, then they should kind of stick to that. I don't want to give 2 liters as the number for everybody, because it's not the number for everybody. Mostly if it's higher, like very hot, humid climates, they might need a little bit more. If they're working out, exercising rigorously, even in colder climates, they would need a little bit more. So definitely I would say, like, I usually say if you don't have a heart condition or heart failure, then stick to about 1.8 to 2.5 to 3 liters, around that range. If you have a heart condition, then stick to 1.5 liters or a little bit less. Yeah, and then dietary wise, sodium is a big one. Even if they're diabetics, of course, processed food, processed sugar, simple sugars are a big no-no, but they should still be adhering to a salt-restricted diet, not as completely, they need to have sodium in their diet. They shouldn't stop it completely, but sticking to about 1 teaspoon, which is like about 2 grams of sodium, that is a good number to abide by, especially because increased salt intake is going to increase their urine ACR as well. So those are a few of the dietary concerns that I would, on the high level, discuss with the patient.
Okay, so there's one question. I'm trying to, please just, if you can restrict them to the Q&A rather than the chat, because it's hard to track the questions on the chat. Clinicians at her institution, at one person's institution, uses both spironolactone and non-steroidal MRAs for diabetic nephropathy. What's your opinion on that? So they use them, just to clarify, use them both at the same time, I think. It says, yeah, use simultaneous, so it means both at the same time, sorry. So yeah, what are your thoughts about that?
I mean, they don't need to at the same time, or doing the same thing.
Yeah, because I think my risk could be hyperkalemia. Yeah.
Yeah, yeah, yeah. If they still don't have hyperkalemia, we should start looking at their adrenal axis. There's something wrong with the axis.
Yeah.
Yeah.
Yeah. So
Definitely, like, I would stick to if finerenone is finerenone widely available in Jamaica?
so I mean, this is a broad call, but we do have finerenone available, and I mean, I know it's available in many Caribbean countries as well. So I mean, because
If
the audience is Caribbean,
If
so
finerenone is
but
available, I would stick to finerenone for diabetic kidney disease, and I would stick to
mhm,
spironolactone for heart failure. It does have a slightly stronger indication in heart failure, but finerenone also has there are new studies that have come out. Finerenone does have good efficacy even with heart failure and has a lower propensity to cause hyperkalemia compared to the steroidal MRAs. Steroidal MRAs also give you things like gynecomastia, which non-steroidals don't really give because they're not binding to that same receptor with the same affinity.
okay. And somebody from Fiji, which is cool. All right. What are your views on using ACE, ARBs in combination with SGLT2s and non-steroidal MRIs? So triple therapy. What is your views on triple therapy? So
I would
using the
definitely
combination.
the combination is what is being advised. If the patient's tolerating it, then definitely that is what is advised, because there's a lot of data and studies that have already happened that show that there's much more improvement in mortality, morbidity benefits when they're used in combination as opposed to not being used in combination. So
Yeah.
definitely that's a big yes. One thing that I would steer clear of is not combining ACEs and ARBs together, no simultaneous use of RAS inhibitors.
Mhm. Right. And I mean, and based on the data, looking at combination therapy, it seems like there are more than there's some of the parts. So meaning that the effect is not additive, it's cumulative. And so, I think the thought is that kind of like how you have the four pillars of heart failure, we should have like the three pillars of kidney disease. And we should really be trying to, as tolerated, right? Combine therapies, especially in our high risk people. And as we know, our high risk people are those people with amenorrhea, and certainly your risk increases as GFR reduces. So I think I'm going to try to look in the chat to see if I found questions. There was a question earlier, and I can't find it now, but I think it was on the use of phenynerone in frail or older patients, which is kind of a good question, I think.
Yeah, that's actually a very good question.
Yeah.
So a lot of actually a lot of my patients are frail, and I do work at the regional cardiac center. So a lot of my patients are frail with heart failure. So they surprisingly actually do tolerate non-steroidal MRAs pretty well.
Mhm.
And a lot of them are actually on spironolactones, and their doses are being decreased, where you see some people on like 12.5, then they go to 12.5 every other day, which is a very small dose of spironolactone. Meanwhile, when they're placed on finerenone, they actually do tolerate the 10 milligram dose, which is the lower dose. If they're very frail, they tolerate the 10 milligram one. And then I've given them 5 milligram daily instead of skipping a day. And they actually tolerate it pretty well because it's not a very strong hypotensive agent as strong as the steroidal MRAs.
Okay. And then there's a question okay, so two questions. So one is from the same person, so I'm going to use the same questions. So one is thanking you on an excellent, a delightful talk and importance of screening. He says that risk of CHD increases as early as ACR reaches 10. My question about GLP-1s, as far as my knowledge, the only GLP-1 studied in diabetic kidney disease was semaglutide, 1 milligram. You kindly mentioned in Lira. So was Lira studied in DKD?
Lira wasn't studied. Liraglutide wasn't studied.
Mhm.
Liraglutide is just there, and I have some patients on liraglutide, but somehow I don't know the exact mechanism of why and how, but semaglutide has better results even in the patient that I've seen in person. But I think if it's not available, liraglutide can be used because it's the same mechanism of action. Maybe just the affinity might be a little bit different for semaglutide versus liraglutide. And now there's Mounjaro, which is the other one that's like a prequel of GLP-1 agonist, which is also showing really good benefits. So if that's available, then that's also something. As long as I think there's GLP-1 receptor agonist activity, it is beneficial. So if you don't have semaglutide, you could use liraglutide, but the studies were done with semaglutide.
Okay. And the next question was, why does the guideline recommend referral to nephrology at a GFR less than 30? It may be too late to reduce progression.
That's actually true. Uh, that's a very good question. It's actually true. It's a KDIGO
Yeah.
guideline. And, I think in my understanding, it might be there because before that, there is something that can be done.
Mm.
And that's why you're stopping it. And you have all those amenities to do. And then after 30, it's so
Yeah.
low. Then it's better. It's just safer for the patient to be followed by the
Mhm.
nephrologist if there's a fast or rapid progression
Decline.
uh,
Mhm.
end-stage kidney disease, then they are already reviewed and they have a process, a plan,
Mhm.
rather than an urgent start dialysis. They might have a few other things that they could be tried on, which the nephrologist might,
Yeah.
or the nephrologist might be able to implement those um, um, treatments with much more force as well.
Mhm. Yeah, and
Um,
I think the thing is it should be that like everyone who's under 30 needs to see definitely. And I think, I guess this is why it's so important to have talks like this so that we know that like we're not getting people with whose GFR is less than 30 and they're not on a RAS, they're not on an SGLT2, they haven't been tried. And an important thing is that, so that's one, why we need to educate like our primary care physicians and our internists and make sure they like are treating people appropriately. Although the world is not perfect, we know that. And the second thing is, the separate points is like more risk stratification. So anybody certainly who has significant albuminuria, has a lot of protein in their urine, so A3 or more, regardless of GFR, they should probably be seen by a nephrologist. If you, one of the KDOGA guidelines point is cause. So, up to a third of people with diabetes and kidney disease do not have diabetes causing their kidney disease. So if you're not sure, if you don't think that this is diabetic kidney disease or their atypical presentation, so someone who suddenly becomes nephrotic, or there are other features on the history that is not suggestive of diabetic kidney disease, then you should really refer that patient. And I think that is said in the guidelines, that they do say that if you're not sure, or if they have a lot of albuminuria, if they have a lot of proteinuria, or a rapidly declining GFR, you should be referring to nephrology. But I think, again, importance of this is that we do have to make sure that primary care physicians are empowered to initiate these drugs and to check for GFR and albuminuria testing to make sure that we're doing that, and starting appropriate therapies. I think that's the kind of importance. But yeah, I agree that GFR, where I hope that the people in the audience are not saying that, oh, we'll wait until the GFR is 30 before we send to nephrology. Please don't do that. Yeah. Yeah. Okay. Another question arises about non-steroidal MRAs. I'm aware that this is not okay. Okay. Could you shed some light on finerenone generics, especially in low and middle income countries where finerenone is costly? At least any insight on that?
Unfortunately, I do not have much idea about the Finland. It is, although Canada is not a low or low middle income country, a lot of our patients can't afford Finerenone either. Because right now it's Kerendia that's making, like Bayer that's making it. I'm hoping for the market to open up so that Finerenone can be made by other companies, but I think they have to wait a certain number of years before that happens. So to my knowledge, I don't know of any other company that's making it right now. Unless someone from the audience is aware of Finerenone being made by other companies. If it is
It
not
has to come off
available,
patent. I think it has to
yeah,
come off patent. Yeah.
yes, and then there's a certain number of years that they have
Yeah.
to.
Before they become generic. So yeah, I mean, I think that's a tough question, because um, I think what we do need to do as, and I guess as a global nephrology community, is really advocate to our governments and also to drug companies, because really and truly, finerenone and drugs like SGLT2 inhibitors have the capacity to reduce mortality and hospitalizations, right? So if you look at it from a cost effectiveness perspective, investing in SGLT2s and finererones reduce costs for healthcare systems that are already underburdened. That I think that's beyond the scope of this talk, but I do understand like cost, because even though we have it in Jamaica, it's covered by a kind of partially covered by like if you're diabetic, it's partially covered by a national health fund. It's still very costly. And I think that is something where we do need to advocate both to government, Ministry of Health, about the cost effectiveness of this, because there's quite a few cost effective trials in SGLT2s. And certainly I'm sure the same applies to finerenone, and MRAs. And so, there's no easy answer to that question, but certainly I do understand.
I think you raised
And
a really good point on actually also one approaching the government, and the second one is the pharmaceutical company itself making it available in the countries where it is actually having a big impact. So yeah.
So my last question, another question on NSA is this is another good question, is any studies looking at non-steroidal MRAs and type 1 diabetes?
There must be. I'm not aware of it right now. Are you aware of any right now?
Yeah, I mean, I know they had some data on SGLT2s, and I think something was presented at ASN about like ASN with type 1 and finerenone. I can check that with you to be sure, but certainly the effect on proteinuria reduction. Um, for
I thought that,
SGLT2s for type 1 diabetes, I know definitely does have some improvements.
yeah, type
And
1 diabetes.
there's one that was presented in one of the clinical trial sessions in ASN last year, that, finerenone does reduce or improve proteinuria, and reduces GFR decline or GFR slope in type 1 diabetics. I'm looking for the paper now, so I'm going to try and see if I can find it in the chat.
Actually, there was a paper on SGLT2
Mm.
inhibitors
Mhm.
that I've come across in the San Diego, the ASN that
Mm.
was there. But then non-steroidals, I couldn't think of any. But the KDIGO guidelines actually do talk about both type 1 and type 2 diabetes. So the studies are probably not uh, there as
Mhm.
robustly as type 2. Uh,
Mhm.
but
But
it is in the
yeah,
recommendation for all diabetics.
yeah.
Uh,
So yeah, there is actually some data. Someone just texted me. So find one. Thank you, Ian.
um,
Find one clinical trial that showed some
perfect.
benefit with type 1. So yeah,
Perfect.
Ian, thank you for that.
Yes.
And a question from an internist: would you recommend referral to nephrology as early as a GFR, a 3A, so someone's GFR between 45 to 59? What are your comments? So if someone's GFR is between 45 and 59, would you refer to nephrology?
There are certain criteria, as we talked about. If we're checking at their urine ACR, if the urine ACR is actually high, then that would warrant a nephrology referral. Also, if it's not fitting the criteria of diabetic kidney disease, then it definitely needs a referral.
Okay.
And if it's like a younger patient, and then there's also the rapidity or the progression that you're seeing, the decline has happened really rapidly, then those would be indications to actually suggest a nephrology referral.
Yeah. Because I mean, we have an aging population with diabetes as well. And this comes up like, so if I have like an 80-year-old whose GFR is 48, who doesn't have protein in their urine, has no amenorrhea. Last year it was, I'm going to make up a number, 50, and now it's 48. That person who's 80 or 85, it's likely, yes, diabetic kidney disease, but without any amenorrhea in an older person, with GFR, with a CKD stage 3A, that patient may not need to see nephrology, but certainly people definitely with amenorrhea, and people with like rapid declines. But we're not going to detect a decline unless we check for declines. So we should be checking patients for both amenorrhea and creatinine testing. That's my
That
final
question is
reminder.
actually a very hopeful question because that means it is being checked.
Yeah.
Yeah, and then I think I had another comment to add on that was usually there's but just roughly if you're assessing somebody's CKD level, sometimes you'd see a creat or a GFR of 58 in a 90-year-old. But then usually if you kind of go by a number in your office when you're seeing a patient, if you kind of take GFR of 90 as a cutoff, and then you do 1% decline per year per patient for that patient if it's after the age of 40. So let's say the patient is 60 years old. Now you're taking 20 away. So if they have a GFR of about 70, 75, then that's okay. It's okay for their age because after the age of 40, they do see 1% kidney function decline per year as a normal aging process.
Mhm.
So there's certain things that you have to be kind of assessing, as Lori mentioned as well. Age is a big factor in there.
So more questions. Well, we always have a lot of questions in these things, but this is great. I really like the discussions. So there's some insight on the use of dual SOTA, dual SGLT1, 2 inhibitors on diabetic kidney disease. Not familiar with that. Are you? Dual SGL1, 2 inhibitors or SOTA?
No, um, I don't have much experience with that.
No, we don't. I'm sorry, we don't have much experience with that. I'll try and see if we can look it up, but I didn't see much data on that. Um, uh, what period is considered a rapid decline? That's a very good question. So what is considered a rapid decline?
So I think we just talked about it right now. If you
Yeah.
see more than a 1% decline per year in
Hmm.
GFR, then you're
Hmm.
kind of little bit concerned. Then you look at their HbA1cs, let's say it has been off this, like it's been very, very high. Then you know that that is sort of coinciding, but still, if you see more than a 2% decline per year, then you're a little bit more concerned about that patient, especially if they're younger, or less than 75, I would say.
Yeah. So for example, if someone's GFR was like you did your test, you do your yearly test for diabetes, let's say the creatinine, the GFR, which was like 40, let's say your SGLT2 inhibitor, you started someone an SGLT2 inhibitor and they're on their RAS inhibitor and their GFR is like 45. And then they have like no proteinuria, their albuminuria is like 30. And then when you check it a few months later, and I say a few months, meaning 3 to 6 months later, and it is now like 35, right? And the albuminuria is worsening, or yeah, it's now 35. I think that person you should be warranted. And the first thing is that, just like any approach to elevated creatinine, is why. Why would this person would have a sudden drop in GFR? That's a 10-point drop. So why would that person? So that's one thing. But I mean, if someone's GFR is declining by about more than two per year, definitely, you want to think about, and especially because oftentimes you guys are going to be following them longitudinally. So let's say in like January, the person's GFR was 75, and then by the following January to do the test, it's like 68 or 65, and then the following year, it's like 59. That person, that's a rapid decline in function. So certainly, that 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 just giving you an example. But sometimes acute kidney injury or acute worsening in kidney function, although this is not a discussion, um, can coexist with chronic kidney disease and often does, meaning that people with chronic kidney disease are more likely to develop acute kidney injury, right? So the question is this worsening kidney function or acute kidney injury? And certainly, I think for the purposes of a primary care doc, if you are seeing like this continued decline over time, then yeah, refer. And I think for the most part, and hopefully I'm not opening up myself to more calls. Like if you're not sure, I think, there's something called, if you're not sure, if you're not clear, if it's not making sense for you, everything is, if the GFR you notice when you text, it's lower each time and you're not really sure if this is true decline, is this just lab variation, then, I think it's reasonable to reach out to the nephrologist. And I think it could be just a phone call or it could just be a referral. So I think guidelines are there to assist you in management, but there's such a thing as slight nuance. So maybe, and this is where things like the KFRE is really helpful, right? So if their GFR is under 60 and you're not sure, then, put it in the equation. And then if they're high risk, you can go ahead and refer. But yeah, don't call me all the time. But yeah, yeah. I mean, what are your thoughts on that, Simon?
No, definitely. I agree with what you said right now. Um, it is actually a case-to-case basis, but then the judgment is, yeah, if there's the rapidity of decline coincides with, more than 2 to 3 in a year.
Okay, so um two more questions, and I'm going to close off because I think it's past everybody's bedtime. So one question is, are there any possibility for oral GLP-1 receptor agonists in the future? Because patients may be hesitant to start injectables.
Yeah, actually there is. Semaglutide is also available in an oral form. There's a daily oral form. I think you go by 3 mg every day for the first 4 weeks, then you increase it to 7 mg for the next 4 weeks, then you increase it to 15 mg. So that's the semaglutide oral one that we do use in some of my patients who are terrified of needles.
Mhm.
And then there is another one that starts with an O, is not very commonly used. I want to say or for something. It's
So
also a P1 agonist.
yeah. There's another question about the role of cystatin C in screening. That's a really good question.
If it's available, then yeah.
Yeah, that would be great. If you have it, so the advantage of cystatin C is not affected by things like lean muscle mass because we know creatinine is. It's kind of the KDOGA guidelines say use it when available. But I don't think it's in the diabetic kidney disease management. It's in the CKD best practices management. So yeah, if you have it available,
I think
see
I
why
had it
not.
on one of my slides. I just didn't read it out because most places it's not available.
Cystatin-based measurements may be useful in your younger diabetics who may have hyperfiltration, right, where creatinine may not be as useful a marker, but certainly if you have it, then you're better than me. You're better than us in Jamaica.
It's very
Um,
sensitive. It's a very sensitive marker, even for like people who have hyperfiltration for obesity as well. It's actually very helpful. So if you have it, please use it.
we will start using this EGFR CKD epi for renal function. So they're asking if they're using if we should use the 2021 CKD epi, the new race-free equation, for EGFR.
It is CKD epi. When was the last time?
2021.
2021. That's the most frequently, like more commonly used one. That's the standardized one.
Yeah. So in European populations, they use they use the CKD 2009 without the race coefficient because it's more, so I guess it depends on your population, but certainly in North America, we tend to use the CKD EPI 2021. So North America, including Jamaica, North
Yes,
America and the
exactly, because we do
Caribbean,
have the
we
same
tend
kind of
to,
population.
yeah, so we
It's a
tend to
mix of
include the
population.
Caribbean in North America. And
Yes.
I guess Caribbean also include the North America includes Mexico,
And Canada, it does
and
not only
Canada
include
and the
America.
US. So and the Caribbean. So we tend to use CKD EPI 2021. But that's a matter of debate actually. So and beyond, we'll be here until 10 o'clock about using equations, but we tend to use the 2021.
Yeah, yeah. That's the most widely used one, especially for population.
All right, so I think it's almost 9 o'clock. I'm gonna say thank you for this really, really good discussion. We had a lot of excellent questions, and thank you for your time. I'm giving a welcome of thanks. Thank you very much, Dr. Behara, for the excellent presentation and also the excellent discussion on your insights on clinical management of diabetic kidney disease. Thank you very much to our host, the CCFP, for our continued collaboration, because this is the third presentation we've done. And I'm looking forward to our next kind of presentation. And thank you very much, Suman, for such an excellent presentation. It was really, really insightful. And thank you, audience, for such excellent engagement and questions. I'm going to turn it over to CCFP.
Oh, well,
Thank
thank you,
you.
everyone.
Thank you so much. It has been such a wonderful feast. And just for the two of you, do you use Trajenta at all? We have Trajenta in Jamaica. What I noticed is that I have a patient and his EGFR was actually going close to 30. And I had a pharmaceutical record come in, and I was talking to her about different medications. And she said, she actually has, but her company markets Trajenta. And the amazing thing, I used it, and the gentleman's EGFR went up back. I took him off. He was on metformin. I took him off metformin as well, and his EGFR just went up back. And it's just fascinating to see, and the medication is affordable.
Yeah. So Trajenta is a DPP4. I mean, it is useful in kidney disease. And I know especially in advanced kidney disease, when your GFR is below 15. There is some data for it reducing progression, but certainly the SGLT data is more robust because it reduces cardiovascular risk as well. Yes. And certainly, I use Trajenta, especially in my patients whose GFR is below, who's low, whose GFR, they don't qualify for SGLT2, they don't qualify for And oftentimes my patients may be on more than one agent, but so far I've been focusing more with the use of SGLT2s. Well, of course, as a nephrologist, everybody uses RAS inhibition, but SGLT2s because of the cardiovascular data. Because remember that people, I mean, as a nephrologist, we need to think about things other than dialysis, because I know that's like important, but a lot of our patients have multimorbidity. So most patients with diabetes also have coronary artery disease. They also have hypertension, they have metabolic syndrome, so the SGLT2 actually helps both the cardiovascular, and I have no ties to SGLT2, so let me start off by saying that. So I'm not, but certainly the cardiovascular and mortality benefit with SGLT2s is there. And the non-steroidal and the finerenone. But DPP4, which Tradjenta is a DPP4 agonist. Those do have benefits in kidney patients, and I do use them. But yeah.
Thank you so much. Well, thanks for shedding some light on that, because I did notice that his eGFR has gone up really well. And amazingly, he actually he had inguinal surgery and it was under general anesthesia, and he did quite well. Just saw him like 2 days ago, and he's beaming, and he's an elderly man.
Oh, that's good.
Yeah. And it is, I just embrace everything that the two of you have said. It was just amazing watching the dialogue between the two of you, and you're a really good team. And to all of us here, we are part of the team, and what the persons from the ISN, the International Society of Nephrology, North America and Caribbean Regional Board have done is to raise awareness. They have raised awareness so well to allow us to appreciate the various nuances in the care of persons who have diabetes and how to actually save kidneys. That is the message. Let's save kidneys. And it starts off actually by doing our screening, right? And engaging the patients and the families, because we all need to go through lifestyle. The kids are eating ultra-processed foods. It is really bad. It is cheaper than healthy foods. And I know recently we had tax on unhealthy foods and drinks, and maybe this may actually help people with also raising awareness why it is important for people to have healthy plant-dominant foods and having the exercise. That's what Dr. Behara was saying, and smoking cessation and weight management. So that foundation is so important. And then she mentioned about the blood pressure control, the lipid management, the blood glucose. We thank her for bringing all of that, and with the RAS and the SGLT2 and the GLP-1. These are the pillars. And we had a wonderful, wonderful discussion about all of this. So it is all a team approach. And we in the Caribbean, well, we are part of the world. We're exposed to a lot of climate changes. So Dr. Behara also mentioned the heat and the dehydration. And we need to also make our patients aware that they need to hydrate, walk around with the bottles of water and hydrate. Some simple things we can actually help them with. We want to help prevent people going toward dialysis because it's expensive, and we really don't want people going there. If they go there, they go there, but we can do something to reduce the rate of them going there. And so we are part of this team. We want to use the toolkits that were mentioned and optimize our care for all persons who have chronic illnesses, especially those who have diabetes, and help to save kidneys. So I thank the ISN and the Caribbean College of Family Physicians for doing this wonderful collaboration. I also thank the planning committee for arranging this, and for Dr. Lynn Thompson, our CCFP administrator, the participants from all over the world, amazing, and our IT engineer, Mr. Samuel Heron of Oldgate Solutions. All of us made this possible, and because all of us are together in this team, we are on the journey saving kidneys. Thank you so much, and have a good night.
Thank you. Bye-bye. Thanks for
Thank you,
having me.
everybody.
Guardians of Caribbean Health, the vital role of family physicians.